G'day everyone, welcome back to 10 Drugs That Changed the World. Remember that before we get into some of the fascinating historical stories surrounding the discovery of new drugs, we want to spend a bit of time laying a basic foundation for a rudimentary scientific appreciation of how drugs produce their effects on the body. And one question we've been examining in recent episodes is what happens to drugs after they enter the human body. And today we're looking at the final process whereby drugs are removed from the body. So what we want to do in this particular episode is convey a basic appreciation for how the kidneys achieve permanent removal of some unmetabolized drugs from the body. Now that might seem a strange objective, but stay with me because we're going to unpack this concept in the rest of this lecture, and hopefully you'll come away thinking that this really is an important domain of pharmacological knowledge. Now remember, to set this in context, we need to recall some of the basic processes that occur when we ingest a pill. It seems a very simple process, doesn't it? But a lot of scientists spend much of their careers studying and optimizing some of these processes. And remember that pharmacists in particular and pharmaceutical chemists are particularly interested in formulating drugs to make pills that after they are ingested undergo this process of disintegration and dissolution. And then pharmacologists get interested once we have individual molecules floating around in the fluid within the gastrointestinal tract, and then they begin these processes of absorption, then distribution around the body. And then there are these two processes that begin protecting the body against drugs by removing them from the circulation. And the first of them we looked at in the last video is metabolism. And today we're wrapping up this little consideration of the pharmacokinetic phase of drug action by looking at this all-important process of excretion by the kidneys. Now sometimes, just to make things a little clearer for you, be aware that sometimes in pharmacology textbooks we talk about elimination of drugs, and this term is used to refer collectively to both of these processes that draw drugs out of the blood, namely excretion in the kidneys and metabolism in the liver. So elimination is a broader term referring to both these processes, but in this lecture we're going to focus particularly on the kidney's role in excreting certain types of drugs. Okay, so remember these processes are really important during the pharmacokinetic phase. These ADME processes, absorption shapes the rate with which drugs concentrations rise in the bloodstream and reach their maximum value. Then distribution denotes the readiness with which drugs penetrate into tissues and achieve effective concentrations in the tissues where we want them to produce an effect by altering heart function or brain function, for example. But then these two elimination processes, metabolism and excretion, begin lowering blood concentrations of drugs. And these two processes, of course, have a lot to do with how frequently we need to administer fresh doses of drugs to replenish concentrations of drugs in the bloodstream. Okay, so remember that in the last lecture we looked at the process of metabolism, and this is a really important capability that the body has to convert some of these greasy molecules that are intentionally designed that way by the drug companies, because of course pharmaceutical companies want to maximize the oral absorption of drugs. They want them to get into the body easily. So to do that, they make them a little bit greasy so that they can get across the cellular membranes lining the interior of the gastrointestinal tract, of the upper intestines in particular. But that's a problem, isn't it? Because, and as we considered in that last video, these greasy drugs can accumulate within tissues that are rich in fatty molecules, and this can result in them causing toxicity. So to get around that problem, we have this remarkable capability due to the presence of DMEs, drug metabolizing enzymes, in the human genome, which produce these remarkable little enzyme catalysts, which carry out chemical conversions of greasy molecules into more water-soluble molecules that can then be excreted by the kidneys into the urine. And remember, this occurs, the kidneys are able to remove these sorts of water-soluble metabolites because this process of zapping the drug to introduce this oxygen and hydrogen group or hydroxyl group converts the drug from being greasy, associated with the organic layer in a simple water octanol system, into a more water-soluble species associated with the water, less so with the upper greasy organic layer. And this, of course, means that the kidneys, which are particularly good at getting rid of small water-soluble substances from the body, the drug is now in a form where the kidneys can do that job easily. Okay, so just to summarise what we're talking about today and set it in the overall context, most of the time, the sort of pharmaceuticals that we ingest during the treatment of various medical conditions, they're often mainly removed by the liver via this process of metabolism that we talked about last week, because many of the drugs that we ingest in the process of pharmaceutical treatments are typically greasy, fat-loving, lipophilic molecules, and they undergo this process of conversion into water-soluble, water-loving, hydrophilic molecules, metabolites that are then transported by the blood to the kidneys and eventually are eliminated by the urine. Now, what we're talking about today, though, is a subset of drugs that already possess inherent water solubility. They're already at that water-soluble end of the spectrum. Remember, we talked about that in an earlier lecture. We can think about pharmaceuticals as sort of inhabiting somewhere on a pole comprising greasy, fat-loving molecules at one end of the spectrum, and then water-loving molecules, hydrophilic molecules at the other end of the spectrum. So molecules up that other end of the spectrum that are already fairly water-loving tend to bypass the liver and get directly removed by the kidneys without any need for metabolism in the liver. Okay, so they come out directly in the urine. Okay, so if we put numbers on these values, this upper subset of drugs, which is subject to what we call hepatic clearance, hepatic referring to the liver, and so the clearance means it's mainly, this is a process whereby the drug gets cleared from the bloodstream, removed from the bloodstream, and so this comprises, this applies to about 70%, not quite 3/4, but almost 3/4 of the pharmaceuticals in current use, small molecule drugs that is, mainly get removed by this process of metabolism in the liver. Now, what we're talking about in this particular lecture is the remainder of about 1/4 of medicines, about 25%, that undergo renal clearance. So these are the molecules that already possess intrinsic water solubility, intrinsic hydrophilicity. They don't need to pick it up during processing by the liver, so they basically bypass those liver enzymes and they directly get excreted into the urine. Okay, so we call this renal clearance. Now, if you're an astute mathematician, you will realise that if you add 25% to 70%, that gets to 95%. So you're wondering what happens to what about the remaining 5% or so of pharmaceuticals? And we won't be talking about that in today's session, but generally speaking, about 3 to 4 to 5% of pharmaceuticals get removed via the feces, via the intestines, without a role for the kidneys in removing either the parent drug or the metabolites. But that's beyond the scope of this lecture. Just to fill in for the sake of completeness, some drugs, yes, go directly out via the colon, via the feces, but we're not talking about them because they're quantitatively not that common. Okay, so what we're talking about today then is that process of renal excretion. And we can define it more precisely as a process whereby non-metabolized and hydrophilic or water-loving drugs are removed from the body in urine after circulating blood is processed by the kidneys. Okay, so the kidneys have this remarkable capacity to filter blood, and after blood enters the kidney via the arteries, it then undergoes this process of filtration within the nephrons, within the kidneys, to result in the drug permanently being removed in the urine. Okay, so we call this excretion when we find the parent drug, the drug in its administered form. So there's no metabolism going on. So I've left them blue here because they're already possessing intrinsic water solubility and they're coming out directly in the urine without any metabolism. Okay, so we don't have time to go into the renal physiology in any detail beyond the scope of this little simple video, but be aware that the kidneys are really remarkable organs. They have an amazing capability to concentrate and excrete the body's waste products, but they also excrete small water-soluble chemicals into the urine. So this is why they're so important in protecting the body against a lot of pharmaceutical agents. Okay, at the heart of the kidney capability to do this are these remarkable nephrons, and these yellow structures here shown in this simple diagram, and are basically big long tubes, and are sort of semi-permeable, so they allow movement of water and certain types of chemicals out of the bloodstream into the tube. And we have and that tube eventually drains into these collecting ducts, which eventually drain into our bladder for eventual expulsion from the body in the urine. Okay, so these are remarkable little filtration devices. We have about 1 to 2 million of them in a typical adult human kidney. So we've got 2 kidneys, so double that number. We've got around 3 to 4 million nephrons in a typical healthy adult organ. Okay, so a typical human body. Okay, so but these are very vulnerable to injury as well. And so one of the real challenges in pharmacology and toxicology is minimizing harm to some of these very delicate structures in the kidney nephron. This is really a major challenge, avoiding the use of or minimizing so-called nephrotoxicity when we use certain types of drugs. Now, another thing we've learned, now if we come back to that diagram, let's say we took a sort of a slice through the tissue and looked down on a nephron and saw its relationship to some of these blood vessels that are winding around the nephron. Okay, so there's continual exchange between molecules coming out of these blood vessels here, and the red blood vessels here, of course, are oxygen-rich arterial blood, and then the blue is venous blood going back eventually to the lungs to be reoxygenated eventually via the venous circulation. Okay, but essentially there are molecules continually moving in and out of the blood into nephrons and potentially back into the blood as well. That makes this process of renal clearance very complicated. Now, one of the things we've learned, so imagine, like I said, if we took a slice through and looked down on the top of that tubule, that kidney nephron, what we would see is that there is a lining. So here's the tube containing the nephron interior containing what's eventually going to become urine. I've coloured it yellow for that reason. And then around the exterior of this tube is a lining of what we call kidney epithelial cells. And this interfaces with the bloodstream. Okay, and if we looked at this in more detail, we would find that there's a key role for some of these important drug transporters that I've mentioned in previous lectures. Now, we haven't gone into the detail at all. There's some remarkable detail surrounding these pumps, but essentially they function as those molecular turnstiles that facilitate the movement of small molecule drugs from one body fluid, including blood, eventually into into the urine within the kidney nephron. Okay, so essentially we have a couple of transporters on both sort of what we call membranes. Some transporters bring drugs out of the blood into the epithelial cell, and then there's some distinct transporters that then move them in that second step into the urine eventually. Okay, so this is a very important capability of the kidney. These transporters really are so incredibly important in protecting the body against small molecules, including many pharmaceuticals. Now, if this was a more advanced course, we'd look at that in more detail, but we'll just leave it at that point for now. Okay, now fundamentally there are 3 processes then controlling the readiness with which drugs are removed from the bloodstream and then make their way into the urine at the kidney nephron. The first of them is a process known as filtration, and this is a little bit like when you're making a cup of coffee, fresh brewed coffee with coffee grinds in a plunger, and you push that plunger down, you're filtering the coffee and forcing the liquid containing all the good stuff through a filter. And essentially this is what happens. The blood pressure as the blood comes through this top of the nephron here, known as the glomerulus, this all important process of filtration occurs, and this is very effective at removing what we might call unbound drugs. Remember, we talked about that in an earlier lecture. Some drugs have affinity for particular plasma proteins in the bloodstream, such as albumin, and they stick onto it and get carried around the blood, around the body, stuck onto the albumin carrier. Well, it's only the unbound drug that's floating free, that actually gets filtered during this process of filtration at the renal nephron. So that's one process, pushing drugs into the urine. And then a second process is where we see these transporters playing a role. and this is particularly up here in the this little folded area. These are known as the proximal tubules, very rich in transporters, these pumps that carry out the movement of drugs, even if it's protein bound. These pumps are so efficient they can rip the drug off the albumin molecule, off the carrier molecule, and move it via this process known as active secretion into the urine. Okay, so both of these processes are tending to push drugs out of the blood into the urine. Now, but you need to realize that the body just can't let go of all its small molecules through the kidneys. It has to be able to recover certain important substances, including glucose. So glucose, very important energy supply for tissues all around the body, released from the liver, and it needs to be utilized around the or tissues all around the body. We don't want all our glucose being lost in our urine. So that's why we have these long extensions, these on the kidney nephron, these so-called distal tubules, and feed into these eventually these collecting ducts, and there's a lot of reabsorption going. So in this process, so this is to recover small molecules including glucose, so this process is what we call passive reabsorption, where molecules go back out of the urine back into the bloodstream. Okay, so the overall readiness with which drugs are removed by the kidneys is the sum of these processes, two processes pushing drugs into the urine, filtration and secretion. But then reabsorption is very important because we actually filter 120 mils of blood per minute, adds up to about over 7 litres of blood gets filtered. So that's 7 litres of urine being formed every hour in a young healthy adult. We certainly don't excrete anything like that volume of urine, thankfully. And so we have this amazing ability to reabsorb some of that water and glucose and other important ingredients, small molecules in the blood. We do this via this process of, in the urine rather, this process of reabsorption, bringing them back into the bloodstream. Okay, so the overall clearance, the readiness with which drugs are removed from the kidneys is a sum of the filtration plus secretion minus any reabsorption. So individual drugs differ according to the readiness with which they undergo each of these three processes. So that's why the overall contribution of the kidney to the removal of drugs from the blood can be quite challenging and complicated. But that's probably enough detail for this particular course. Now, what we want to know, though, as pharmacologists, is how do we discriminate between drugs that are mainly removed via the kidneys directly without any metabolism in the liver versus those that do get metabolized in the liver. So to get this sort of information, it's really a very simple calculation and analysis that's performed. We calculate a thing called the FE, which is the fraction excreted unchanged. Now, remember, I've described in some of my earlier lectures just simple numerical values that pharmacologists use to get a handle on how certain drugs behave, or individual drugs behave in the body. We looked at the F oral, and that's a fraction of the drug that gets absorbed out of the bloodstream, or into the bloodstream out of the gastrointestinal tract after oral administration. That tells us a lot about the absorption of drugs. And then we talked about the volume of distribution, the V-dist, which is important in knowing how readily do drugs penetrate into tissues, or do they tend to stay mainly in the bloodstream. Another useful number that tells a pharmacologist a lot about how an individual drug behaves in the body. But another number that's very valuable in the context of the removal of drugs, these two processes of elimination, is the FE. And we calculate this by giving a dose of drugs, let's say 100 milligrams of a drug, to a human volunteer, and then we collect all their urine for 24 hours and then send samples off for analysis in a laboratory. And we're wanting them, the chemists, to measure the amount of parent drug recovered in the urine. Okay, so we use this in a simple calculation, and let's say in this particular hypothetical example, 5 milligrams of that parent administered drug X, was recovered in the urine. So we calculate the FE by dividing that amount in urine by that dose administered. So it's 5 milligrams coming out in a full bucket, divided by 100 milligrams, that amount we administered to the individual. So 5 divided by 100 is 0.05. So this is telling us, so the maximum for an FE is 1. So if it's 1, it means all of the drug administered to the patient comes out unchanged in the urine. If it's 0 or low, like 0.05, this drug doesn't get cleared very well at all by the kidneys, and it's mainly getting metabolized in the liver. Okay, so this FE is really valuable because it tells us in a glance as to which of the two major excretory organs of the body are dominant in removing a particular drug from the bloodstream. On the one hand, we have the liver, which is very good at metabolizing those greasy, fat-loving molecules, and at the other end of the spectrum, we have the kidneys, which are very good at removing water-soluble hydrophilic molecules. Okay, so the FE tells us where an individual drug lies on those two extremes. If the FE is 0, that tells us that the liver is dominant. So a low FE, let's say less than 0.1, tells us that drug is mainly being metabolized in the liver, and very little of that parent drug gets collected in the urine during that sort of experiment that we just described. On the other hand, a high FE drug up to 1 or less, let's say greater than 0.9, that tells us that the drug is mainly cleared by the kidney with little or no metabolism occurring in the liver. Okay, now of course many drugs fit somewhere in between those extremes. It might have a FE of 0.3 or 0.7, and that'll tell us that a certain amount of the drug is removed or eliminated from the blood by the kidneys and the remainder by the liver. So the two added up together contribute to the overall elimination of drugs from the blood. Okay, so let's just look into our medicine cabinet and have a look at a few real-world examples of drugs with these different types of fates within the body. On the one hand, high FE drugs, these are the drugs that come out in the urine without having been metabolized at all in the liver, and it includes many penicillins. We might talk about penicillin in one of our future lectures. It's certainly a drug that changed the world, and some fascinating history surrounding the discovery of the role of the kidneys in removing penicillin is really quite fascinating. But also gentamicin, another very important antibiotic that's used in treating pretty serious infections, particularly within a hospital setting. And then metformin, a drug that's used to treat diabetic patients to lower blood concentrations of sugar. Also a drug that's almost exclusively removed with very little metabolism in the liver, exclusively removed in the urine. On the other hand, some other drugs that we're probably quite familiar with can mainly get metabolized in the liver and with very little drug appearing unchanged in the urine. Okay, so this includes morphine, one of the most famous pain-relieving drugs, well known to history. Paracetamol, or acetaminophen as our American friends call it, a widely used non-steroidal and analgesic drug. It's exclusively removed by the liver. Just 1 or 2% of the drug can be found in urine unchanged, so we're dependent on the liver to protect us against paracetamol. Efavirenz, a drug that's used in the treatment of HIV infections, also predominantly metabolized in the liver. Okay, but that's just a few of the medicines in the contemporary pharmaceuticals cabinet, but just gives you an example of sort of drugs that fit into different types of categories. Now, you might be wondering, does it really matter? Who gives a toss, really, whether a certain drug is mainly removed by the liver or mainly removed by the kidney? Does it really matter to the overall pharmacology of the drug? People other than pharmacology pedants who worry about these things, should anyone else worry about them? Well, yes, we should worry, because just to wrap up this lecture, we'll just indicate situations where it really does matter whether we're administering a drug that depends on a healthy liver versus a healthy kidney in order for the body to remove it and protect the patient against that particular pharmaceutical. And some particular subsets of patients where we need to be careful include frail elderly people, because as we get older, the capacities of our liver and our kidney can decline. So our drug clearing capabilities in those two organs goes down with age, and sometimes one organ will tend to give out ahead of the other one. So some elderly people might have limited kidney function, others might have limited liver function. The same is true for people with other types of medical conditions where they just have kidney failure, for example, or they might have liver failure, perhaps a history of alcohol abuse and cirrhotic liver disease means that they have a limited capacity to process certain drugs by the liver. And another famous example of a very important group of patients that, where we have to think very carefully about these issues are the little premature infants born ahead of their due date, and because the development of the liver and the kidney occurs often during the postnatal period and even continues for a year or more, we can't assume that a drug that's safe for use in adults is necessarily safe for use in this particular vulnerable group of patients. Okay, so as a result of this, these basic considerations, sometimes when we're dealing with certain types of drugs, and particular drugs with narrow therapeutic windows, remember we talked about that in my first video, therapeutic window refers to the margin of safety between safe concentrations of drugs and those that cause harm in patients, especially when we're dealing with those sorts of risky types of pharmaceuticals. We need to be really careful and pay attention to whether the liver or the kidneys is important in removing those drugs from the body, and whether that particular organ that dominates for a particular pharmaceutical is actually in good shape in a particularly vulnerable patient, such as an elderly person or a preemie. Okay, so that's what clinical pharmacology often is all about, thinking through those sorts of issues, making sure that we're matching the right drug with the right patient. Okay, we've been through a lot in this episode. Sorry if I've gone a bit over your head, but this is wrapping up the final consideration of pharmacokinetic topics. But let's just quickly recap what we've learned in this particular session. Firstly, we've seen that about a quarter of medicines are removed from the bloodstream by the kidneys, and they undergo very little or no metabolism in the liver. Such so-called renally cleared drugs often possess inherent hydrophilicity, that is, inherent water-loving character, so they don't need to pick it up during processes by DMEs in the liver. So they don't have much lipophilicity, so they're not very good substrates for those enzymes. Okay, so they bypass the liver and get removed effectively often by transporters in the kidney directly into the urine. But that process of drug excretion by the kidneys is very complex. Contributions by three fundamental processes: filtration, active secretion and reabsorption, and the summation of those three processes often determines the overall readiness with which drugs come out in the urine. And then finally, we've seen that this handy little number, Fe, the fraction excreted unchanged, can tell us in a glance how important the kidneys are in removing the parent drug from the blood of those patients, and we can use the Fe as well as a therapeutic window to guide drug selection, particularly when treating patients that have poor liver function or poor kidney function. Okay, that's probably enough for excretion of drugs. Hopefully you've learned a little bit from this episode. When we come back in a future episode, we're going to change gears. We've wrapped up our consideration of pharmacokinetics. Now we're going to look at the other side of the coin of any pharmaceutical, the one that many pharmacologists spend their entire careers studying. How does that drug work? What does it do to the body? So we're going to look at some basic concepts of so-called pharmacodynamics. What does the drug do to the body in my next episode? Thanks again for watching. All the best and take care, and see you soon. Bye-bye.